Hello everybody again, and welcome to this lecture. We are talking about anterior dental aesthetics, and of course we try to follow all the objective parameters that we can find it, and also we should also consider the phonetic test as an important tool in order to really achieve the best result in our prosthetic rehabilitation. We will show some cases on implants and some cases on teeth, and of course we try to understand how important will be the anterior dental composition that we can find at the end of our work. Let me show you what are the most important steps that you should follow when you talk about teeth and implants on dental aesthetics, anterior dental aesthetics. First of all, I would like to show you that is important the anterior dental composition, as I already said. A very, very important step that has to be followed 100%. And then the symmetrical gingival levels that are absolutely very important when the patient has a high smile line or gum smile line, which is visible. And then again, the presence of interdental papilla should be more or less at the same level all the time. And of course, the adequate color of the abutment can be on teeth, and that is more complicated to have the color that is perfect. If you have marked discoloration, it will be much easier today with implants with a ceramic abutment to be white and to be not marked discolored. And last but not least, the use of all ceramic restoration that is helping us a lot on achieving the best result. So let me start with the anterior dental composition. Even though I want to tell you that my thought is that I should find some discrepancies between the right and left sides to really be more natural as possible. Many patients today don't want to become really misaligned or maybe different from one side to the other side. Our patients normally want to be wide and aligned 100%. Even though that is quite a fake kind of overall view, the patients are happy with that. That's the problem. So I try to tell you how I believe we can achieve the best result in terms of aesthetic result anteriorly if we follow some rules, some parameters in a proper way. Even though, again, I don't like to be perfect right and left, I would better to have maybe lateral incisors that are not perfectly aligned 100%, more in, more out. But the patient doesn't want to have this kind of result. That's the problem. So our goal is that to have the patient that are happy without having any kind of a compromise that is not acceptable. Of course, should be an acceptable compromise just in case you believe that is a compromise. So actually, I would like to start. The first step that we should follow is the incisal edge position. That should be convex. And the convexity will be depending on the class. Is a class 1, class 2, class 3. Class 3 will be almost flat. Class 2 can be much more convex. Class 1 will be more or less normal. So that is decided by the incisal curvature that they anyway have some convexity. And the two central incisors, as you know already, represented the most convex part of the incisal edge. So incisal curvature is the first step. The second step is the dominance of the central incisors. So the ratio and the relationship between central incisors and lateral incisors. The dominance of central incisor is a must, especially today for aesthetic reason. And then we talk about the long axis. Long axis with axial inclination that is more divergent, more will go from central incisor to the cuspid on the cervical area and more convergent in the incisal area. So you could see these drawings here and showing this line, these long axes that are inclined more and more from central to cuspid. And then the interdental contact areas, interdental contact that are extended more incisally in the two central incisors than lateral and than cuspid. As you could see, they are forming more or less a kind of other curve parallel to the incisal edge curvature, at the same time forming this kind of interincisal angles that are wider and wider more you go from central incisor to cuspid. So interincisal angle here is smaller than this and than this that are wider. Right and left, identical. And if you join together all the red little steps here, they are parallel to the incisal edge position. That is more or less this kind of harmonic relationship. Plus, when you talk about the tooth arrangement, you could see the lateral incisors that are a kind of jolly joker of the anterior dental composition, that are within two hypothetical lines that you can draw from cuspid to central incisor. Incisally, as you could see with the red lines, with the green lines, and cervically. So the lateral incisor will be within these two lines. If they are higher position or lower position, will be immediately visible by our eyes. Our eyes as observers, not as dentists, even observers, lay people crossing the street. They can understand something wrong. And then we have this situation, the gingival outline, that see the lateral incisors cervically in more coronal position than cuspids and central incisor. Last but not least, still on the gingival outline, please don't forget the papilla level. The papilla level should follow, even in this case, the same kind of parallelism, or a kind of parallelism, between incisal edge, interdental contact areas extension, and, again, papilla height. So please don't forget it. That should be achieved in terms of having an ideal anterior dental composition. Let me show a case that is not possible to show completely, but just to understand more or less the concept. This is a case that was made by myself, but together with the orthodontic surgeon, that is Mirko Raffaini, and the orthodontist Dr. Cocconi. And we decided that the final position of the upper teeth should be changed in this way, with the maxilla advancement and the down grafting. That's a long story, but just to be short, actually we changed to have the overbite over jet and to have the possibility to have also a kind of function, not just aesthetics. After many steps that I cannot show you, we have the implant placement. We moved the cuspids that were in the lateral area, lateral position area, to the distal part. So now we could, at this point, have the chance to position a couple of implants there. Stefano Gori did the implant surgical procedure here, but look at the beginning situation. We have a kind of anterior passive eruption on the posterior area. At the same time, we have still not the complete healing and maturation of the soft tissue after the surgical procedure. So we have this situation that is not really the one that we would like to achieve in terms of lateral incisor position that are outside. And the cuspid are too short. Now we decided to do this kind of surgical procedure on the back side. And that's the way how we improve it, elongating the cuspid areas. At this point, the lateral incisors are within the two lines. As you could see, if you compare the first picture to the second picture, you can understand that the final outcome is much more nice if you look at the right side instead of the left one, because the lateral and the right position, because we increase the length of the two cuspids. As I said, we did this kind of we changed this altered passive eruption. We did this surgical procedure on the back side. At this point, we elongated also the bicuspid, not just the cuspid, but also the bicuspid and the molar. At this point, at the end of the final outcome, we have prepared these 4 teeth with the veneers, with the enamel presence 100%, and we position 2 implants as we said. Our goal is that we know already to obtain the ideal dental composition in order to have the satisfaction of the patient. And we have the chance to finalize with lithium disilicate this kind of work. As you could observe that the lateral incisors are now in the right position. You could say that, generally speaking, talking about the anterior dental composition, the ideal one, we had the chance to see that we have a nice curvature of the incisal edge, right? And then we have a very good dominance of central incisor. And then we have also the lateral incisor within hypothetical lines between cuspid and lateral incisor and the central incisor. And then we have the interdental contact area extended to the central incisor more and more than lateral incisors and than cuspid, obtaining at the same time a kind of interincisal angles that are wider and wider from central incisor to lateral incisors and to cuspids. And the lateral incisor in more coronal position than central and the cuspid, and the papilla with a nice level, even though not perfect 100%, maybe between 21 and 22, but is still good, at the same level, right and left. The situation of the lateral incisor that was not there. We have a cleft palate, in this case, that was creating this kind of big hole you could see there. It's very complicated to put an implant to do aesthetic result, to make a good aesthetic result. But I asked Eric Van Doren and Stefano Gori to help me surgically. And we obtained nice result in reconstructing this area by soft tissue and bone. And actually, I could start later on to really condition the soft tissue, recreating a new kind of pressure to achieve good papilla height. We have some pressing on this area, buccal area, but we have the growth of the papilla height. And you can understand here the difference between the beginning and after the final outcome. We are still in provisionals, but you can notice that the provisional are right now in a better position than before. And we have the chance to see that we have right now a good final outcome. Togliete questo schiarimento di voce, chiaramente. The oral environment, you see that the papilla height seems to be quite nicely positioned, and also the gingival outline seems to be quite nice, integrated biologically. But still, we have not found a perfect result in terms of length incisors, on the cuspid and the laterals. With the black pencil we designed for our surgeon, what we should like to have it in terms of final outcome. So we have improved with minor change on the surgical procedure, with the minor surgical procedure change, and we have the chance to optimize this level, as you could see from this picture, and with the lateral incisor that are within these two hypothetical lines, especially cervical, is quite clear that we could have the chance to improve it. And at this point, we have the situation under control. Lateral incisor now is completely different than before. There was an area of really undersized volume, and now we have a nice volume, nice papilla, nice gingival outline. You could say that they are quite similar to that of the other side. It's quite correspondent to the other one. The ceramist is Paolo Rossi in this case. We start from these, with the original situation, with this uneven level of the gingival outline and uneven level also on the incisal edge. We have now the situation that was out of the control at the beginning, that changed completely. It became really completely different. We have to change also the volume and the shape of the central incisors according to the request of the patient, that are more rounded, a gentle teeth, as she said. And you could see that we have achieved this result. And again, once more, we have the ideal dental composition that is achieved thanks to these rules that we have seen together. So lateral incisor, cervically and incisally, that are within these kind of two lines, from cuspid to lateral, to cuspid to central, and then the interdental contact areas that are extended more and more from cuspid to central incisor, more incisally. As you could see, this creates a nice kind of a curvature that is quite similar to that of the curvature of the incisal edge, and the forming, again, interincisal angle wider from central incisor to cuspids. And then you see that also the gingival outline seems to be absolutely the one that you want to achieve, because they are in the right position, even though are not perfect 100% maybe, but it's quite close to the perfection. Let me show you this kind of case that is a particular case, because the patient was complaining about some pain on all the anterior teeth that were treated endodontically, and also they were treated by the thermal bleaching procedure that was heated inside. The material was heated inside the canal, and that's created this kind of resorption. Unfortunately, we had to remove all the 6 anterior teeth, and that was really, really bad for the patient, but also for us, because then the request of the patient was particular request. I want to explain to you. If you look at the Eisenman line of the patient, you can see the total length of the teeth that are measured in 10.60. That is quite normal length for lady, for men. But what we know, at this point, being visible 100% of the gingival outline, we shouldn't lose any height. We should keep the bone as it is, the gingiva as it is. But what happened is that even though we know that when you have implants close each other, is more complicated to have a nice papilla height, in this patient, she wanted to have not any kind of bridges. That was a very precise request by our patient. Okay? She said to us, I don't want to have any kind of bridges. So I want to be actually, I need to have all single restorations. So it's a nightmare for us. For me and for Eric Van Doren, that was the surgeon that made this case. He did a great job putting some connective tissue graft on the back side of the implants. We, at the beginning, had the chance to position 4 implants on the 4 anteriors, and having the chance then to have a provisional from cuspid to cuspid. We have removed the crown on the 2 cuspids on the upper jaw, and we create a provisional that are not loaded on the implants, but loaded only on the 2 bicuspid, the 2 cuspid, the right and left side. So at this point we did this provisional. We positioned the provisional close to the implants, but not really touching them, not loading them. The time of surgery, that is with the provisional in place. And after 3 months, again, with this provisional in place. Now we are waiting for the osseointegration of the implants to do now the loading of the 4 implants anteriorly and remove the 2 cuspid to put other 2 implants on the 2 cuspid. So having the provisional that was loaded on 4 implants and with the 2 cantilever on the 2 cuspid, even though it's not the ideal case of having cantilever, but of course we can remove all the contact on the cuspid guidance. We believe at this point that we have a group function that will be better, of course, in this situation here. So, certain point, before having the final osseointegration of the cuspid, or at least the final conditioning of the soft tissue of the cuspid, we had the chance to condition the 4 anterior areas, the 4 incisor anterior area with our provisional in the better way. But at the same time, what happened is that the patient asked us to do as much as fast as possible because she need to move to go to Australia for 1 year. So what to do at this point? We had not the chance to condition the soft tissue of the 2 cuspid, only the 4 anteriors. So the 4 anteriors were copied in some way. We had the chance to remove the provisional from the patient mouth, to put the provisional in the replica of the implants, and then to screw this provisional on this kind of replica. It became like one piece. We position it into the patty. The patty was created. We push this into the patty, but not completely, almost completely, but not completely, because then we rely with some light material of impression, polybiloxane material, light material, in order to have the best kind of reproduction of this transmucosal path shape and contour. And now we kept in place, and then we waited for a few minutes. And once it was done, polymerized 100%, we should have removed the provisionals, and we could have the chance at this point to see the transmucosal path that is completely clear and well reproduced in order to be copied 100%. So everything was done appropriately in order to achieve this kind of result. And that's the impression copying in place, position in place, has to be filled with some resin that can be white, can be red, as you like it. But once you do, you position this kind of impression copying, customized in this way, into the mouth of the patient. We didn't do that on the cuspids, the 2 cuspids, the right and left. Why? Because we had not the chance to replicate something that was tested in the patient mouth, because the patient was rushing us. You have to finalize in 1 month because I have to leave to go to Australia. So that's the reason why we had not time to do our best. But anyway, we try to do our best. And that is, again, the way how we conditioned the soft tissue of the provisionals, but not in the cuspids, without resin, without any kind of a conditioning there. So the patient then was ready to receive the case, we had the chance in the lab to optimize, at least theoretically, the cuspid area too. We could copy these areas with the soft tissue red, with the pink soft tissue that you can see here, but not the one that on the cuspid that they were almost invented by the technician. We received the 6 abutments in zirconia that seem to be quite well done. We have the good chance to even modify if you have some little discrepancy on fit. For example, we have a little misfit over here between the composite, between the zirconia abutment and the provisionals. Some there also not perfect 100%, but we still can realign or put some flowable around it and close completely, because you have the chance in this case to have, yes, the abutment in ceramic abutment is something that is between the root and the abutment. So you have both in your hands. That it never happened to have in your hands with the natural dentition. Natural dentition are root inside. You cannot see. You cannot manage the root. In this case, you can manage. You see in the way we manage. So now you can check the buccal contour. Thanks to the connective tissue graft that Eric Van Doren they made on this buccal area, you could see the very good result. But that is the occlusal view. But if you look the same case on the frontal view, if you remember what we have seen before with you in terms of anterior dental composition, please take a look and see how different is the ideal one to what we achieved. We have not still the soft tissue that's still mature, are not mature yet. We have to wait it, but we cannot wait in one hand because actually the patient has to leave. So we try to improve the situation in comparison to what we see here. First of all, we have the 2 central incisors are not the same height, and we believe the right one is the right length and proportion. Then the 2 cuspid, you could see you should elongate cervically the right cuspid and shortening maybe the left one, theoretically at least. What else? What about the papilla? Papilla were not good. They are very constricted. So you have to enlarge a little bit the space to facilitate some growing of the papilla. So we should increase the length there, decrease it a tiny bit the central and more the cuspids. We did some modification, and you could see that again I can put my abutment in the model and still modify what? Modify also the line between abutment and root. Again, you cannot do practically in the patient mouth with a natural dentition. But if you look at, if you see that there is something that to be changed, I try to reduce and altering the buccal support of the implant. And this way, I can have the chance then to refine. Look, now there is a kind of over-contour there. Over-contour that I can remove it by my burr. You see, that is over-contoured. So I put more in. My abutment at first and my provisional second. So at this point I can have all these less supported. So the concept is the following: altering soft tissue levels by the design of your pros. In which way? Reducing the buccal support. And the buccal support will be reduced thanks to the fact that we have removed this margin on the zirconia and then to the provisional. Again, you cannot do that on teeth or on implants. Especially on the left cuspid. Remember, the left cuspid was very high level. I have to reduce the level. So we should reduce the over contour now, horizontal over contour of the provisional, as you could see here. And then you have to remove the old over contour with a burr, and until you have achieved the same level of the zirconia abutment. In this way, you can achieve in 1 week already a better view. Now, the 2 cuspids are closer each other, the 2 central incisors are identical, and the papilla start to grow a little bit up. So, we are changed in 1 week. Now is the time to finalize the case. We have another 20-25 days to wait the maturation of the soft tissue before the patient leaves. And at the same time, the technician can finalize the work. he was recreating the zirconia abutments again with over this abutment. He put 6 anterior alumina crowns. We are now layering all these crowns in the proper way in order to find the best aesthetic solution. We kept the position of the incisors and the cuspid within the border of the silicone index derived from the provision that were tested and proved in the patient mouth for quite some time. And that is what you obtain in terms of final outcome. And the day of delivery of the case, that is the result. That is quite surprising because now it's almost perfect. Even though we have 6 implants underneath, don't forget it. Very complicated cases. 1 year later, the patient came back, still very good, even better maybe. We obtained quite nice aesthetic and biological integration. But once more, I would like to analyze with you, after having checked also the X-rays showing interbond peak level that was remain perfect between the teeth, between the implants, some growing of the papillas, and again, showing again, as I said, the ideal dental composition that was achieved even in these very complicated cases. We have started with incisal edge curvature, very well done, and then interincisal angles wider and wider thanks to the extension of the contact areas between the 2 central incisors that are more incisal than lateral and central and lateral and cuspid. So interincisal angle wider and wider. Lateral incisor within these 2 lines, incisally and cervically. And then lateral incisor more coronal than central and cuspid. And last but not least, the papilla height. They're not perfect 100% as should be, but I believe having 6 implants close each other, I believe that is very good result anyway. That is the case that was after 1 year. So not long time term, but is still good because 10 years later, it's still in good position. We have maybe some little change on the level of central laterals, but believe 10 years later, I believe that is really good, especially on the smile of the patient. So let me change in a while this part and shift to the aesthetic and phonetics. Why I'm talking that? Because that is very important for anterior aesthetic. That is the title of our presentation today. We have already seen maybe together what we can do with the F sound. F sound is a classic sound that can help you in having the chance to define and determine if your incisal edge is too far away, too backally positioned or not. Because we have on the lower lip line the vermilion border, that is the line that is dividing the wet part of the lower lip that is internally positioned to the vermilion border, or the external part of the lower lip that is the dry part of the lip. If you are too far away, too backally positioned, you could have the chance to create some tuberculous on the lower lip line. If you are within the vermilion border and the wet part, that is the internal part of the lower lip, at this point you can have the chance to really stay in the proper position without creating any tuberculosis and inflammation. So let me start saying the patient, saying 55, 55, 55, and showing me that is internally positioned. So it means that I could come a little bit more out with my restorations, even if I will maintain my position within the vermilion border. I don't have to go out. So the vermilion border of the lower lip is the maximum limit within which the incisal margins of the restoration should be positioned. That's a very important consideration, prosthetic consideration for aesthetic rehabilitation. So that is possible to test it with the F and V sound. But I believe the most interesting sound is that of S sound. S sound is very well known, being a kind of so-called the closest speaking space. It means when you talk and you say S sound like kisses or like Mississippi or maybe 66, you can see that the 2 arches are getting closer and closer and closer. The maximum contiguity between the 2 arches is obtained when you say Mississippi with the S sound. Okay? That's very important to remember. So if you increase the vertical dimension, for example, that can create a problem, because at the beginning you can have the chance to touch the teeth all together. I'm talking about teeth everywhere, also posterior teeth. They are touching because you have increased the VDO. And until you don't gain a new kind of neuromuscular position that are avoiding this contact, you still have this kind of lisping of S sound. That is one of the two important steps for S sound. The other one is the following. You can read here, mandibular movement and tooth position. Very important, tooth anterior position now. Why is it important? Because some people, like these drawings showing, when you say 66 or Mississippi or S sound anyway, they go with the mandible more in front, almost touching the upper and the lower teeth together. But that could be a problem. I want to show you why. Look in the patient in the lateral view. Some patients keep the mandible, as I said, in a retruded position, and other one, in contrast, protrude the mandible until reach the head-to-head position between the maxillary anterior and the mandibular teeth. So, if your goal is that to achieve a good aesthetic result, improving or increasing the tooth length of the incisors, for example, or the upper jaw, how can you do it? Let me show you a couple of patients. Left one of my dental assistants, Michaela. Look, she's talking, but she's keeping the mandible in a retruded position, as you could see. Not going in front. Far away, incisors in the lower arch are far away from the incisor of the upper. Now look Antonietta, the other one. Now you can see the better way with the ralenti in a while. But you could immediately see, look in front, go in front, now back, go head to head. Head to head. So if Antonietta needed an increase of length and the teeth were already shortened, how could I do it? I will touch the new elongated part will be actually encounter my movement, that is horizontal movement. So let me show you this lady. This lady needs to be rehabilitated. They are very short teeth. She should be improved in terms of aesthetic result everywhere, of course, but they have kind of cutted teeth on the, and what we would like to achieve is this result, of course, improving the length of upper anterior teeth, and together with that to having a good harmonic relationship with the lower lip line that is concave. So now look at this patient. That was the movie on the left at the beginning, was made by a colleague that sent to me the patient. It shows clearly that the mandible goes in front. Look, and going edge to edge. Look at this, going edge to edge, going in front. So how can I elongate these short teeth that are just 7 millimeters long? How can I do it? And on the right side, you see already the answer. Why? Look how long the teeth are. I elongate it. 3 millimeters, 0.5. 10.5 now the new length. How could do it? They were touching each other already when they have a short teeth. Now we have elongated, how you can avoid it? That could be the question. Take a look now. Now, she is not going in front anymore. She's staying back to the back. She has transformed the horizontal movement to the vertical movement. It does allow you to achieve good result. That happens 90% of our cases. Don't be wrong. Don't be afraid. That can happen. That can happen. Having good result in terms of a kind of adaptation of the stomatognatic system. Muscles readapt to the new position. Not always happen. When it doesn't happen, what to do? That's another question. Let me show you. If you have a vertical movement, we said no problem. Why? Because we don't change. You can change the length without having any problem. Now, in this case, we have changed already the length, okay? Having to change the length, if you have horizontal, you go against. What to do it? First, we have to talk to the patient in advance, saying that could be possible. I know the answer. I have to shorten it. I have just lengthened. Why I have to shorten it? It's not ideal, of course. It's not good. So what else? What we can do? What we can do? Maybe we can shorten it. no more the upper that we have lengthened for a purpose to have a better aesthetic, but we can shorten the lower. Could be an idea if they are involved in the treatment, first of all. Second, what happened in occlusion? Because you have shortened this kind of occlusal contact. You have no more contact when you close the mouth on the normal relationship in a maximum closed patient. You have no any contact, but still you have a possibility to increase the balcony and to have more thickness of the palatal part of the upper teeth. At this point, you have still the contact. At this point, you have not lose the anterior guidance. And that is maybe the solution. If you have at the same time the possibility to work on the upper and the lower. So going back to the lady is happy with the new case. That is not this one, of course. That was the beginning case, the starting point, the starting case. Remember that we discussed about the central incisor length, 10.6, 10.8, 11. That is the average. The most important is the proportion between width and length. The width should be around 80% of the length. So 11 the length and 9 the width. Of course, in natural you can find many different variations, but the proportion will be anyway between 75 to 85%, the width of the length. That are all the values that many authors showed, and that to have the chance to achieve these results. So we did some mock-up, of course, before, and we have the chance to anticipate to our patient what will be the final outcome, so the patient can check it, but not just check the new length, not just check the new mock-up, but also looking with the mock-up if the lower teeth were still going edge to the upper, because they will touch in the part that was elongated already. But once you did it at the beginning, maybe she is also having this kind of impact with the lower incisor to the upper incisor, because the movement was the horizontal movement. But after a while, the patient will readapt to the new position and stay in place in the retruded position, change this position. Of course, at the beginning, the patient can complain. At the time of delivery of the mock-up, say, oh, I will touch here, it's not going on well. And if you don't know exactly that could happen, you don't anticipate to the patient, it will be problematic, because the patient has to be informed in advance. So they can rely on you, they can trust you, they can say, oh, he knows that could happen. He advised me to say, look, now try, if it's going well, okay, if not, we try to do, as we said, talking also about the modification of the lower arch, the lower anteriors. But most of the time, again, they are able to achieve the very good result, as I said. And that is what to obtain also in this case. That's with the mock-up, before and after. And that's with final work that is made with the 6 anterior porcelain plus all the posterior areas are still on ceramics. So we start with that, we finalize with this, and we achieve a satisfactory result for the patient. And I believe that is our goal. And again, the phonetics, even on anteriors, takes an important role. So just to summarize what we have seen in this chapter, in this lecture, talking about anterior dental aesthetics, I would like to, again, support the fact that it is very important today to have an ideal dental composition. Patient wanted to achieve this kind of result. If you are into the parameters that we have seen together, I believe that it's very important that we can achieve very reliable, predictable, and constant result all the time. The patient will be very happy on that. Secondly, we should, of course, do our best in the patient who have a high smile line to achieve a very nice level of gingival outline, not different right and left, even though it's symmetrical, we have a symmetry, specularity, this sometimes even too much. It seems to be fake. That is what the patient like to have it. Ideally, 100% of the case, they want to be really the same level, right and left. Third, of course, if you have not a chance to do that because prosthetic not possible to achieve this result, don't forget to have some help from the surgeon or from the orthodontist. In both cases, you can achieve the best result in terms of gingival outline and having the chance at this point to really create the best result moving the teeth a little bit or moving the gingiva a little bit. At this point, you can have the chance to optimize the level on the eye-smile line. And last but not least, don't forget the phonetics. I know that nobody take care about that normally. It's the old concept, but still very useful if you understand exactly on the basis of the sound that you emit. That is very important in some cases, especially with the S sound, with the F sound and S sound, to be ready to really create the best final outcome for our patient once you have tested properly these kind of sounds, this phonetic test. Okay? I hope that you enjoyed this lecture. See you soon. Bye.